Welcome to the World Medical School. My name is Professor Dimie Ogoina. I'm an infectious disease physician and the president of the Nigerian Infectious Disease Society. In this micro lecture, I'm going to be talking about clinical review of human Mpox. As a form of introduction, Mpox was previously called monkeypox because it was first described in captive monkeys. Traditionally, Mpox is a zoonotic disease and is typically characterized by febrile generalized rash illness, like what they call pox-like rash illness, which is similar to the picture we have here. Mpox is caused by the monkeypox virus, which belongs to the Poxviridae family of viruses. This is the same orthopox genus as variola, which is the cause of smallpox, and as well as the Yersinia and cowpox viruses. There are two distinct genetic clades of the monkeypox virus. Clade 1 was previously called the Congo Basin clade and has now been subdivided into subclades 1A and 1B. Clade 2 was previously called the West African clade and has also now been divided into subclades 2A and 2B. Historically and based on epidemiological data, clade 1 has been shown to have higher case fatality than clade 2. The Mpox or monkeypox virus is a double-stranded DNA virus that is brick-shaped, has a length of 220 to 450 nanometers and a width ranging from 140 to 260 nanometers. Let's go over the brief history of Mpox. The monkeypox virus was first discovered in 1958 when there was an outbreak of a pox-like illness amongst captive monkeys. These monkeys were exported from Singapore to Denmark, following which they developed pox-like lesions that were later identified to be a new virus. And because it affected monkeys, it was called the monkeypox virus. Following this outbreak, there were other outbreaks that were reported between 1958 and 1968. Most of these outbreaks followed the exportation of non-human primates, mainly from Asia to parts of Europe and America. It was only in 1968 that non-human primates were exported from a part of Africa, which is Sierra Leone, to France, and that resulted to an outbreak. The first human case of Mpox was reported in a 9-month-old boy in a rural setting in the rural rainforest areas of the Democratic Republic of Congo. This boy was not vaccinated for smallpox, and he was discovered during the search for smallpox in a period when the world was attempting to eradicate smallpox as a public health threat. Transmission of Mpox can either be animals to human, from animals to human, that's the zoonotic route, human to human transmission, and also environment to human. Those are the major three routes in which Mpox can be transmitted. Human to human transmission, the secondary attack rate may vary from 0 to 11%, depends on the degree of exposure and the type of exposure, and this is usually amongst the unvaccinated. Of course, the secondary attack rate is much lower in people that had previously been vaccinated for smallpox. The basic reproduction number is usually between 0.3 to 0.8. So of course, it could be higher in cases of outbreak and could approach 1 or 2 in the setting of an outbreak. If you look at the transmission chain of the monkeypox virus, of course, the agent is very clear, which is the monkeypox virus. Unfortunately, we have not been able to identify the actual reservoir for this virus. Rodents and non-human primates are believed to be potential reservoirs for the monkeypox virus. The portal of entry/exit is usually from infected body fluids and infected tissues. Mode of transmission can be contact related, both physical, sexual and non-sexual physical contact, droplet related, foodborne, vector through fomites and other vectors. Of course, it is possible for Mpox to be transmitted when there's aerosolization of infected aerosols from during the medical procedure, and Mpox has also been known to be transmitted through genital fluids and during sexual intercourse, so it's a sexually transmitted disease. So the portal of entry can include the respiratory route, the skin, the mucosal surfaces. Of course, mother-to-child transmission has been reported, and there's also a probability that it could be transmitted via blood in the case setting of high viral loads, although there have been no reported cases of direct transmission during blood transfusion. The susceptibility factors will vary, may include advanced HIV and AIDS. Pregnancy can also pose a risk factor. A number of pregnant women, especially in Africa, have been shown to have more severe disease. And other factors that may contribute to immunosuppression, including nutrition and genetics, may affect the presentation of Mpox. Let's briefly talk about the pathophysiology. The portal of entry of the monkeypox virus can be through the respiratory route, the gastrointestinal route, the skin, and the genitals. When the virus enters, it multiplies at the portal of entry and then gets to the blood. In the blood, it multiplies in the blood, and that results in a primary viremia, which is responsible for most of the prodromal symptoms that we see in cases of Mpox. After that, it goes to the lymphatics and the reticuloendothelial system, which accounts for lymphadenopathy and sore throat that is characteristic of cases of Mpox. Then it goes back to the blood and where we have a secondary viremia and further constitutional symptoms. Then it recirculates either to the skin or mucous membrane, where patients present with skin eruptions. And then it can recirculate to various organs, and there could be organ-specific complications. So the incubation period may vary from 3 to 14 days or even less. Some studies have shown that the incubation period of even up to 2 days, on the average of 6 to 7 days. That's the average incubation period of Mpox. So the WHO proposed monkeypox case definition has categorized Mpox into suspected, probable, and confirmed case. A suspected case is a person who is a contact of a probable or confirmed Mpox case in the 21 days before the onset of signs and symptoms, and who presents with any of the following: acute onset of fever, headache, myalgia, back pain, profound weakness, or fatigue, or a person presenting with an unexplained acute rash, mucosal lesions, or lymphadenopathy, and for which the common causes of acute rash or skin lesions do not fully explain the clinical picture. A confirmed case is a person with laboratory confirmed Mpox infection or a monkeypox virus infection by detection of unique sequences of viral DNA, or by real-time polymerase chain reaction, or by sequencing. So a number of clinical conditions can be a differential diagnosis of the skin eruption that are characteristics of Mpox. In view of the varied presentation of Mpox, as either vesicular, pustular, blisters, ulcers. So foremost on the list is varicella zoster or chickenpox, especially in the African setting. It's very common concomitant infection in people with Mpox, and this image here gives us an example of a patient with chickenpox with vesicular eruptions. Herpes zoster, measles, herpes simplex, bacterial skin infections, disseminated gonococcus infection, and various STIs can also mimic Mpox. The picture below gives us an example of chancroid and herpes genitalis, which are clinical conditions that can also mimic Mpox. Various allergic reactions and drug reactions, for instance, Steven-Johnson syndrome. There's also a picture here of somebody with blisters that has also been shown to be a differential diagnosis of Mpox. Let's look at the clinical course of Mpox, which describes how the natural history of disease, especially in classical and sometimes in non-classical Mpox. Following exposure, human infection of Mpox can present either with asymptomatic disease or asymptomatic infection. Historically, asymptomatic infection has been described in 18 to 30% of cases, and the symptomatic infection could affect a varying range of persons between 1 month to 69 years. In Africa, for instance, most people that are affected are below the age of 15 years, especially when it relates to clade 1 infection. So following a symptomatic infection, it goes, of course, the presentation can be varied from mild, moderate, severe to fatal infection. And it goes from prodromal symptoms to skin rash to complications to sequelae, then relapse and reinfection. For prodromal symptoms, these are various symptoms that occur in patients that have Mpox before they develop a skin rash. And it may come before or during the onset of the skin rash. And it's usually called the pre-eruptive or invasive stage of the disease. Then they develop the skin rash, which is the eruptive stage, and this skin rash could be at various sites, which are listed here. And they could also have different manifestations. They could be monomorphic, pleomorphic. They could have different body distributions and different characteristics. And note that skin rash can also occur in the genital area. The eruptive phase, in this phase, the skin rashes evolve chronologically from the macules to papules to vesicles to pustules. They cross, they scab, they fall over, and the normal scale is formed. And this process takes 2 to 4 weeks. So on the average, the time to resolution of Mpox lesion is for a period of 2 to 4 weeks. A few of the patients can develop various types of complications. These complications can follow secondary bacterial infection, where they have superimposed bacterial infection of their skin lesions. They can also have septic dermatitis and sepsis. They could have bronchopneumonia, which could be due to secondary bacterial infection. They could have significant vomiting and diarrhea. They could have keratitis and corneal ulceration. And some patients have also been known to develop sepsis, encephalitis, and extensive ulcers and different other complications. Sequelae that have been reported are largely related to skin-related sequelae, pock marks, hypopigmented and hyperpigmented scars. Some patients with extensive ulcers that did not heal properly have developed different types of contractures with attendant deformities. Relapse and reinfection have been shown to occur infrequently in Africa in the global north. And the true burden of relapse and reinfection is an area that deserves further studies. If you look at the pathway of care for patients with Mpox, it starts with the screening of a case to identify a typical case of skin eruptions and to describe that skin eruption. Then we categorize the case as a suspected case. Then we subject that case to diagnostic testing, in this case through real-time polymerase chain reaction. We also do a triaging and clinical assessment of the case. If the case is confirmed through the PCRO, it's a time to decide how we manage the case. If it's a mild case, we might want to choose home care if we are sure that the patient can maintain adequate infection prevention and control and prevent person-to-person transmission in the home settings. Otherwise, we offer hospital care for severe cases and in cases where we need to isolate the patients to prevent person-to-person transmission. After the hospital care, after recovery, the patients are followed up for a period of 3 months or 6 months, depending on the type of presentation and their symptoms at follow-up. Then they are subsequently discharged from care. So, if you look at there's a relationship between the clinical course of human Mpox and the treatment that is offered. And this just to emphasize that the treatment of Mpox begins from the time of exposure and even after recovery because of the varied manifestations that patients can come in. So there's a care of skin and compromised mucosal surfaces that occur when the patients develop skin rashes or mucosal lesions. Of course, you want to treat complications. Nutritional support is very important. Then supportive care in order to address the most troubling symptoms. Every case of human Mpox requires counseling and psychological support because of stigma, discrimination, anxiety, fear, panic that's associated with exposure to Mpox and the consequent manifestation that sometimes can be very disfiguring and may affect the self-esteem of patients. So if you look at the components of management of Mpox, it involves various aspects that's listed here: care of skin and mucosa, psychological support, counseling, supportive medical care, specific therapeutics, treatment of complications, and nutritional support. So there are some special populations that we need to give particular attention to. For instance, neonates and infants and children, they are at risk of developing severe disease. And also they may have concomitant infections. For instance, in Africa, we have children having concomitant measles, chickenpox, malaria infection. So there's need to pay attention to their treatment and care, and also address other ongoing health problems, including vaccination regimens that they are supposed to receive, and also their feeding. Pregnant women have been shown to have severe disease, especially related to clade 1 in the DRC, and there is need to pay attention to their prenatal delivery and antenatal care because also of the risk of mother-to-child transmission of Mpox. Counseling and follow-up is also very important to identify any vertical transmission that may occur sometime after delivery. People living with HIV, especially those with advanced HIV disease, have been known to have more severe manifestation of Mpox, and also have been shown to more likely to have complications and also more likely to die. It's important we pay attention to the treatment with antiretroviral drugs, and it should be started as soon as possible. And we watch out for immune reconstitution inflammatory syndromes, and also for drug-to-drug interactions that may occur with antivirals. Patients, as Mpox is a sexually transmitted disease, we must pay attention to people that are sexually active and also address other concomitant sexually transmitted infections that may occur. It is advised that following recovery from Mpox, individuals are expected to use condom or abstain for at least 12 weeks after recovery in order to obviate the potential transmission of Mpox via genital secretions. So let's talk about the landscape of Mpox antivirals. Several antivirals have been used either on compassionate ground or emergency use for the management of Mpox cases, learning from the experience of smallpox. And the list of the antivirals that have been used historically are listed in this table. Tecovirimat, cidofovir, brincidofovir, and Yersinia immunoglobulin antivirals have been used in management of Mpox cases, mainly on compassionate and emergency use. Unfortunately, none of these drugs have been shown to be efficacious following clinical efficacy studies. For instance, the PALM-007 trial, which was done in DRC, did not reveal any clinical benefit in terms of the primary outcome for clade 1 Mpox. Other studies are ongoing whether this drug can be useful for clade 2 Mpox. Brincidofovir is a drug that is currently undergoing clinical trials to see whether it could be efficacious in the management of cases of Mpox. So in conclusion, the management of Mpox is mainly supportive. It's important to address the most troubling symptoms, which could be constitutional symptoms and symptoms related to skin rash. It requires a multidisciplinary approach that involves the public health physician, the infectious disease specialist, the dermatologist, the counselor, the psychologist, and every other person that involves in the comprehensive care of patients with Mpox. And there's need to pay attention to special populations, including infants, children, people living with HIV, people with concomitant STIs, and those that are pregnant. There's existing knowledge gaps that relates to the clinical cause of Mpox. For instance, the role of exposure type and viral clades in the natural history of Mpox is currently not well defined. The role of specific therapeutics, so that's an area that we need to do more work to determine specific therapeutics that could be useful in the treatment of cases of Mpox. The immune response to Mpox and the duration of immunity, the protective immunity following vaccination and natural infection is also not well defined. And the incidence and risk factors for reinfection and relapse have also not been well defined. In terms of recommendation, there is need for, of course, more research to define the natural issue of the disease, and the need to conduct more clinical efficacy trials on diverse range of antivirals. And there's need for more investment in terms of funding and capacity building to improve the management of Mpox. WHO has, of course, released guidelines for clinical management of Mpox that gives an overview of steps to manage cases and how to apply infection prevention and control in the management of such cases. Thank you for studying with the World Medical School.